Hi there. My name is Rebecca Shatsky, and I am a professor of medicine at the University of California, San Diego, and the breast medical oncology team leader. And I'm here today talking about hormone receptor positive HER2 negative metastatic breast cancer with my good friend and colleague, Dr. Reva Basho. Dr. Basho, do you want to introduce yourself?
Yes. Hi, everyone. I'm Dr. Reva Basho. I'm a breast medical oncologist and currently serve as the Chief Medical Officer at the Ellison Medical Institute in Los Angeles. And I'm really excited to be in this conversation with my good friend and colleague.
Great. So, Dr. Basho, today, what I really want to focus on, especially, is how you make decisions about therapy in the second line setting for hormone positive, HER2 negative breast cancer. I know it's a really crowded space and there are a lot of different things that come into play. How do you approach a patient who has, say, progressed on their CDK4/6 inhibitor and aromatase inhibitor in the first line setting, and you're looking for their next line of therapy? How do you go about that decision, and what factors come to play?
Yeah, it's such a exciting time because there are so many options, but it's such a challenging time for selecting the right option, right?
Yeah.
And it's become so important that we have sequencing data on our patients, right? So when we enter that second line space and patients are coming off of their CDK4/6 inhibitors, genomically guided therapy is increasingly important. And we have to make sure that we have data on the PI3 kinase pathway, PIK3CA mutations, AKT mutations, PTEN, and then also ESR1 to be able to select the right treatment. So I'm pretty proactive about genomically testing my patients at the onset, so at the time of diagnosis, because I know those PIK3CA mutations are truncal mutations, and that's good data to have for when that second line approaches. But then I tend to do liquid biopsies at the time of progression as well to make sure I have that data. And then really I select my second line based on the genomic data that I have.
Genomically targeted sequencing data. Yeah, I'm so glad that you brought that up because I'm right there with you. I really truly believe that all metastatic breast cancer patients need to have their tumor sequenced, and whether that is liquid biopsy or solid tumor sequencing or both, I'm 100% on board. I think it needs to be done, early and often.
Yep.
Um, and I love that you brought up the difference as far as these PI3 kinase mutations being truncal mutations,
Mm.
because, I think it gets missed a lot when we talk about this, that you can find that PI3 kinase mutation in that primary breast tumor if that's the only sequencing for tissue that you had, or in liquid biopsy. And so you have kind of complementary options there too. If you don't find it in your liquid biopsy,
Right.
you still can go test the solid tumor as well.
Yeah. Yeah.
And I totally agree with you as well that this is a really complicated second line now as far as the breast cancer spectrum. Hormone positive, HER2 negative options have really exploded.
Yeah.
A lot of drugs on the market, a lot of things to take into consideration. Let's talk about the space where a PI3 kinase mutation is found. So, that's on the sequencing, they've progressed in their first line therapy. What features of the disease and sort of goals you want to achieve take into account as far as picking a therapy
Yeah.
for that next option?
That's such a good question. We know now from multiple trials that those patients have worse outcomes compared to the wild type patients, right? So we want to be very proactive about identifying those patients and proactive about bringing in targeted treatment that hits the pathway if we can. One of the primary things, of course, is how do they do with endocrine therapy in the frontline setting, right? So some of those patients are going to have such aggressive disease biology that they may have primary endocrine resistance or don't really respond to the combination of endocrine therapy and CDK4/6 inhibition. And really, at the time of first restaging, they've already progressed. And even though we want to bring targeted agents to those patients, I might be quicker to look for an ADC in that type of a patient.
Mm.
But for patients who've had some meaningful disease response in the frontline setting on endocrine therapy, even if it's not the median PFS, but they've had some disease response, at least 6 to 12 months, I'm inclined to stick with the endocrine therapy approach and really bring in a targeted agent with the hope that we can maintain them on endocrine therapy for some time longer. And we've had such success with some of our PI3 kinase agents that we are very inclined to give it a try if we can.
Yeah, I'm glad that you brought up endocrine refractory disease because that is something that still happens. And in that select group of patients, I do think that I would take the same approach as you, is not necessarily jumping towards a targeted therapy option if they truly had progressed immediately on their first line therapy of CDK4/6 AI. For these patients who have what we would consider endocrine sensitive disease, um, do you feel differently if, say, they had a PI3 kinase mutation versus an AKT versus a PTEN mutation?
Well, I might think about it a little bit when I select treatments, right? We have multiple agents available to us. A lot of our treatment selection is based on toxicity, and which I'm sure we'll get to is a very important topic. We know these agents carry unique toxicities, and we really have to think about them in the context of each patient. But, when I do see a PIK3CA mutation, I always do pause and think, do I want a direct PI3 kinase inhibitor? Because that is an on-target agent as opposed to a more downstream agent. Now, that comes generally with added toxicity, and it's always a balance of the toxicity versus the efficacy. Certainly, if I have downstream alterations, PTEN or AKT, I'm inclined to sort of go with AKT inhibitors. They tend to be a little bit better tolerated and are certainly efficacious at hitting those alterations.
For the AKT inhibitor, as far as FDA-approved options, of course, we really have one option right there that is going to be FDA-approved and on label for AKT and PTEN right now, and that drug is Capivasertib. As far as PI3 kinase targeting options, we still have the drug Alpelisib. There are newer drugs coming into this class, but Capivasertib absolutely can be used in that setting as well. So, as you mentioned, we know that a PI3 kinase mutation can infer some more aggressive disease biology. Now, how common is that in this hormone-positive, HER2-negative breast cancer population? What's the incidence of PI3 kinase mutations?
We know that PIK3CA mutations are very prevalent, right? So about 40% of hormone receptor positive metastatic breast cancer patients are going to have a PIK3CA mutation. The incidence of AKT and PTEN mutations are much lower, about handful, 2 to 3% of patients for those mutations. So those are much less frequent. In terms of agent selection, the PI3 kinase inhibitors like Alpelisib and Inavolisib are really limited to patients with PIK3CA mutations because they inhibit the PI3 kinase directly, whereas AKT inhibitors, which work more downstream, inhibit the pathway at a central node. So patients who have PIK3CA mutations, PTEN mutations, AKT mutations all qualify for AKT inhibitors, which inhibit the pathway at the central node.
Yeah, yeah. Important point that probably gets lost a lot is just when you're thinking about this mutation in breast cancer, you can just look back at a slide sometimes, remind yourself of that biochemical pathway that we have PI3 kinase here at the top, and then, AKT and PTEN, and they have different functions, of course. AKT being mostly a gain of function, where PTEN being a loss of function. And then they all kind of centrally go towards your mTOR 1 and 2, as far as causing the cell to signal. And so, that's an easy way to just look at that quickly and remind yourself that the Capivasertib, which is an AKT inhibitor, can work on all 3 mutations, the Alpelisib, the Inavolisib, and some of those newer generation PI3 kinase mutations are not going to work when you have an AKT or a PTEN.
Right.
Yeah, or mTOR. As far as patient selection for these therapies, what things come to mind as far as who would be a good candidate for a drug in this class, either Alpelisib or Capivasertib?
Yeah. I think one of the biggest challenges, of course, is hyperglycemia, because that is a toxicity that requires a patient to be very aware of the monitoring requirements, how often they need to be tested, how often they need to come in, so that we can monitor the fasting blood sugar and make sure that our sugars are staying within range. And so making sure that the patient is aware and able to commit to those testing requirements, and then also whether they have any underlying diabetes or risk factors for diabetes, and do we need to think about prophylaxing those patients, are really important considerations before thinking about either of these agents.
Yeah, absolutely. So toxicity is a really big issue when you're targeting the PI3 kinase pathway in general.
Mm-hmm.
As far as class effects, we know that these drugs can cause hyperglycemia, they can cause diarrhea, they can cause rash, all of those, and somewhat edema, are sort of class effects for most of the drugs that we know can target this pathway. Um, some have higher rates than others. And I think that that is something that really weighs heavily into my decision of which drug to choose. The hyperglycemia rates with these agents really, to me, is striking when you think about the inclusion and exclusion criteria for the different clinical trials. For example, with Solar One, they excluded patients who had a hemoglobin A1C that was higher than 5.7.
Wow.
And I don't know about your patient population, but mine certainly, there are quite a few people, who knows, maybe even me, that have a hemoglobin A1C that's higher than 5.7. Um, it was interesting. The Capitello 291 trial, which is the registrational trial for Capivasertib, allowed patients with a hemoglobin A1C up to 8, which was so far the highest of any drug in that pathway. And even then, the difference in hyperglycemia rates was really striking. You had a very high number of grade 3 hyperglycemia rates with the Alpelisib versus much lower numbers with Capivasertib.
Yeah.
Um, you know, the other toxicity that I really think of as far as targeting this pathway is rash. What has been your experience using different drugs in this setting as far as patients experiencing rash?
Yeah. So I would say that I have seen a little bit more rash with AKT inhibitors, but with more recent data and guidelines, I've started to use antihistamine prophylaxis, and that has been so effective. Ever since I have started using antihistamine prophylaxis, it's a rare patient that I'm treating rash in now. So I think that a simple prophylactic action can be so effective in terms of managing toxicities. And with
I
the
agree that the second generation antihistamines, uh, the non-sedating, has made a world of a difference in the rash incidence in my patients. And so, I think it's important too, just from experience, that they get started on it prophylactically, because I think it's much harder to treat a rash once it's there than if you prevent it. And so that's one of those things that I make sure that my patients, are starting before they start the drug, the Zyrtec.
Yeah.
And that's the one that I find most effective. I've even gone up to BID if they did end up developing a rash. But I've found that to be so helpful as well.
And even, with the hyperglycemia, I don't know if we discussed this, but in Solar One, the hyperglycemia rates were so high, about 25% of patients actually discontinued study medication on trial. I mean, this
Yeah.
is on clinical trial where they're being monitored and treated and
And had to have that very low non-diabetic baseline.
right, right.
Yeah.
And so that's a signal as to how difficult it is to manage the hyperglycemia in the real world setting. So when I do prescribe these agents in patients who have either elevated hemoglobin A1Cs at baseline or have risk factors for diabetes, I am pretty proactive about starting metformin off the bat as well. And I've found that's really effective in terms of managing the hyperglycemia also.
Yeah, me as well. I think that metformin there works pretty well. The only overlapping toxicity issue I see sometimes is metformin can cause diarrhea, and
Yeah.
all of the drugs in this class can cause diarrhea. So I do a lot of patient education
Yeah.
before start of therapy that, if you do have really severe, well, not even really severe, if you do have diarrhea,
Mhm.
we want to probably add an antidiarrheal early. I don't want to see patients get dehydrated because metformin is, really bothering them and we just didn't know until our next visit.
Yeah, absolutely. Totally agree. A lot of education about Imodium
Yes.
before starting these medications.
Yeah, and how many you can take. I think most patients, like, I'll ask how many Imodium you're taking in a day, and they'll find that it's been 1 and felt like it was refractory to that, but
Right,
in the cancer world, we know that there are so many more.
right, right.
The last point, I wanted to sort of make here was, some of the newer PI3 kinase agents too. So, we have Inavolisib and, I think that when we talk about things like hyperglycemia or rash and all, we do need to remember that these are class effects. And so in some of even the newer drugs, these are things that can happen as well.
Yeah.
What's your experience with Inavolisib been so far?
Yeah, I agree with you. Even though Inavolisib has some properties of being mutant selective and wild type sparing, I certainly still see hyperglycemia in the patients that I treat with it. And we know from Inavo 120, we saw, again, a very restrictive trial in terms of enrollment. So patients were restricted to have a hemoglobin A1C less than 6 for eligibility. And despite that, over 50% of patients had hyperglycemia. So even with the wild type sparing,
Yeah.
we're seeing some of the hyperglycemia
Yes,
effects.
a big challenge in this pathway for sure.
Yeah.
Um, and of course, I do want to make sure that we're comparing apples to oranges of Anavo 120 being approved in a different setting, which is the first line setting in combination with palbociclib and fulvestrant for those patients who were recently relapsed on their adjuvant endocrine therapy.
Right.
So a little bit different patient population, but important just when we're thinking about drugs that are targeting this pathway, of
Yeah.
course. Each of them has their very different clinical trial criteria, and toxicity profiles are quite a bit
Yeah.
different.
Yeah.
How do you feel about diarrhea with Alpelisib versus Capivasertib versus maybe Inavolisib?
Yeah. I mean, I've seen diarrhea with all of them. I would really say it's a class effect. And like I said, the Imodium is key. I mean, having that conversation to educate about Imodium off the bat and
Yeah.
make sure they've got it on hand, do they use it right when the diarrhea starts so that we're not chasing and really sort of being proactive about it has helped tremendously. And I think your comment about particularly those patients who were either on metformin or starting metformin prophylaxis, being very careful about the overlap diarrhea is really important too.
Yeah. I think it's important when we think about these targeted therapies because so many of us have experience managing chemotherapy toxicity that we think maybe, oh, these are a little bit less um, dangerous in some settings. But I think it's really important the patient education component
Yeah.
and as well as the nurse case managers, the advanced practice providers,
Mm.
all of those patients, and as well as the attending physician who take care of the patient as a team, need to know how to safely take care of patients on targeted agents because it is really important to be upfront with the patient and your team about what's possible here so that we can make sure that we all safely take care of patients together.
Yeah, it really is such a team effort with these drugs because those patients will call with issues, and making sure your team has the right information to give them right off the bat while they're sort of touching base with you is so important.
Totally. And it can minimize, patients needing to come off of therapy. Early and aggressive symptom management on these,
Yeah.
there doesn't have to be high discontinuation rates, which I think, would be the easiest way just to say, stop the drug, go on to something else. But as we all know, these can also be really powerful drugs.
Yeah.
So when we talk about some of the data from the clinical trials as far as response, this can be another 6 months to a year plus of progression-free survival.
Yeah.
That's really important to patients as far as adding that time in their armamentarium of therapies to prolong patients' lives ultimately.
Yeah. Definitely. And educating our endocrinology partners too, because so many of these patients do end up seeing an endocrinologist because of the hyperglycemia, and making sure they're aware that these are not patients we want to reach for the insulin quickly because we don't want to mitigate the benefits of these agents, and
Yeah.
make sure they're aware of which antihyperglycemics to really reach for in these patients is very
Can you
important.
speak to that a little bit more? I feel like that's a lost point that doesn't get talked about enough when we talk about this.
Yeah, so we know that starting insulin in patients who have hyperglycemia as a result of inhibiting the pathway can actually counteract the efficacy of the drugs. And so we don't want to reach for the insulin as our first line of defense. Metformin, SGLT2 inhibitors are really sort of the preferred agents. And so making sure our endocrinology partners are aware and know that this isn't a patient who's presenting with new onset diabetes, but rather drug-related diabetes, and that needs to be managed differently.
Yeah, I think that's super important. On a similar sort of note there, how do you feel about the use of GLP-1s in this setting?
Yeah, that's a big question, eh? We just don't know yet. I know that a lot of my patients, for sure, are already on GLP-1s or are interested in getting on GLP-1s. I don't have enough data about how it really changes
Yeah,
the
as far as
hyperglycemia, but it's
resp
something we really need to know. We
Yeah.
need to understand better.
Yeah, I feel like that's a big question we're gonna get more and more.
Yeah, for sure.
And there certainly are, ongoing clinical trials of how that may impact breast cancer
Yeah.
in this way or that. We don't quite know the answers to that yet, but something to look out for in the future.
For sure. For sure.
So, key takeaways from what we've discussed today on targeting the, mTOR pathway. I'll give it its more general name, PI3 kinase pathway. Toxicities, data, what you're excited about in the future. Thoughts?
You know, isn't it amazing? It's just been a few years of having these agents, and now we have multiple agents that we're talking about today. We've gotten so much more comfortable with using these agents. We've got data on prophylaxis and management of AEs. We've got better tolerated agents. So a lot of progress has been made, and we know these patients have worse outcomes. So it's great to have drugs that target this pathway. There's a lot on the horizon with new drugs, and we'll just have to see how those drugs fare. We'll have to see how combinations go,
Yeah.
because that's going to be a big, important topic over the next couple of years. So
Yeah, I would say, I agree. That's one area I'm really excited about is combining some of these drugs, especially ones that have lower toxicity.
Yeah.
Maybe when we look forward to the oral SERD data,
Right.
that as that evolves, combining those with these targeted agents instead of fulvestrant, which I think we've all been trying to get rid of for the past, 25 years, is there should have been a very low bar there, just no very painful IM injection with a viscous substance, but we've made the bar on oral SERDs a little higher. I would have a lower bar even, like, with combo agents there. It's gonna lead to happier patients,
Yeah.
you know?
Yeah, definitely being able to give oral agents that allow them to travel and live their lives
Yeah.
is very, very meaningful.
Yeah, this is so important as far as maintaining quality of life is, having drugs that don't cause the kind of toxicity where you have to hang around and be available for an oncology visit at any moment's notice,
Right.
and being able to travel, to keep your hair,
Yeah.
to, not be tied to an infusion center. All of these things are really important things that specifically for this breast cancer population, for us that treat breast cancer exclusively, I think they're really obvious, but, to the greater population, I don't know how general oncologists these days keep up and do everything. I'm in awe of them. But these are the things that I think that we're really excited about as far as maintaining quality of life and while we're giving more progression-free survival and overall survival.
Yeah. So it's certainly very exciting times in hormone-positive breast cancer. A lot more options for our patients.
Yeah, and these NCCN guidelines, they keep getting updated like every few months now. So, ASCO and NCCN being living guidelines because there's so much happening in this space.
Yeah.
Yeah, it's exciting to see these changes as they evolve. Well, thank you for joining us today for this discussion around hormone positive, HER2 negative metastatic breast cancer. I hope you found this educational, and thank you for listening.
Thank you.